we have Lina and Stefano. It's a great pleasure to have you on board. Hello, how are you? So the podium
Hello, Felix.
Hi, Felix.
Can you hear me?
Yeah, we can hear you, we can see you, so the podium is yours.
Perfect.
Okay.
Good morning, everybody. We are very happy to be on board on this wonderful event. And thank you, Felix, for set up this great transmission. What we have today is to show you a transbronchial approach to a peripheral nodule using a body vision system that you have already seen in the presentation before the connection, and ultra-thin Olympus bronchoscope, and also we will use and we will integrate the system with the ultrasound mini probe Olympus to be safe that the nodule is centered. So if you agree, Felix, Lina will perform the procedure, and as first we will show you the case.
Yeah, go ahead.
Okay, go ahead. So the first slide, the slide that I would like to show you is, manda la diapositiva, la seconda, okay. Can you see the nodule is a nodule located in the left upper lobe, and we have no diagnosis, is a patient 81-year-old, former smoker. He had some cardiac problem in his previous history, but now is well. And the CT scan was performed for other reason, and this nodule is 18 millimeter in diameter and was an occasional report, an occasional without any symptoms related. So we will use, as I told you, ultra-thin bronchoscope, 3 millimeters in diameter with a working channel of 1.7, and we will use also an ultrasonic probe, mini probe, that can be inserted in the working channel of the ultra-thin bronchoscope, and we will navigate to the nodule using the body vision system that I will show you during the procedure. We go home. The patient is in general anesthesia and is ventilated through a laryngeal mask. We will move in the bronchoscopic suite to start the procedure. So the body vision system is a system that is integrate the CT scan image with a fluoroscopy. So we have an augmented fluoroscopy that will identify very well the location of the needle. The CT scan of the patient has been uploaded before the procedure in the system, and as you can see here, here is a tablet that is connected with the system. You can see the pathway to reach the nodule that is generated automatically by the system itself. So we have to follow this bronchus in red to reach the nodule, and when we will be close to the nodule and we will verify on real-time augmented fluoroscopy, we will use the ultra-thin mini probe, ultrasound mini probe, to verify that the nodule is really in this position. And then we will go on with the transbronchial needle aspiration and rows to verify if the diagnosis is obtained. So, Lina will start the procedure. The patient is in general anesthesia. You can see the fluoroscopic C-arm that is connected with the body vision system. Is a normal C-arm, is not anything special. The system can be integrated with any kind of C-arm fluoroscope. So go on. The first step is to synchronize the fluoroscopic image, identifying the carina, the main carina. We put the bronchoscope on the main carina. If we can have the fluoroscopic image, dice a Michele che mette l'immagine fluoroscopica. L'immagine fluoroscopica. You can see here the carina. Pronto? La telecamera esterna. Dai. Sì. And you can see here on this pad where is the carina, and we will synchronize the CT scan images and the fluoroscopic imaging, putting this symbol, that means the main carina, exactly where the carina is.
So you have to do a so-called registration, like we learned that we have to do that from electromagnetic navigation and all the other technologies.
Yes, it's something like this. Okay, now you can see that the carina is exactly where the symbol is, and now we are ready to start. Il monitor grande della scopia. Ecco. Now the system asks us to make some adjustment. You can see 3 centimeters, we have to decrease the body position and to move 9 centimeters left and 5 centimeters toward the head of the patient to synchronize everything. We move the bed of the patient in the different position according to the indication that the system gives us. Okay. Now we check again if everything is okay. Okay. Still 3 centimeters to move, and you can start to visualize the location of the nodule on the fluoroscopic view. Is a yellow image. Okay, you can see the yellow image. You can see on the fluoroscopic view the pathway with the red line to get to the nodule. And now we will go on with the bronchoscope following this pathway. The bronchoscope, I still remember, is an ultra-thin bronchoscope, is a 3 millimeter diameter and working channel 1.7. We have still to make the synchronization to localize better the nodule on the fluoroscopic image. We rotate a little bit the C-arm. And now the position is perfect. And we can go on with the bronchoscope. Il pad, Michele. I think is the posterior segment of the upper lobe. This is 1, 2. You can see here on the pad what we will see on the fluoroscopy. And you can see is an augmented fluoroscopy obtained mixing the CT scan image and the fluoroscopic image. Okay, you can see that the bronchoscope is very close to the lesion now. Lina go through the posterior segment of the left upper lobe bronchus. And now we have to check if we are exactly into the lesion. And to do this, we will use an ultrasound mini probe that can be introduced into 1.7 working channel of the bronchoscope. Now the mini probe is introduced.
Stefano, can you switch to the EBUS image?
Of course, to the EBUS image. Yeah. Quella là deve andare. Can you see the EBUS image now?
Yeah. We have it.
Okay. Un po' più dietro, Lina, un po' più dietro, un po' più dietro, un po' più dritta. Ecco, esci così. We are searching for the nodule, un po' più dietro con la sonda, col broncoscopio. Not yet identified, yes?
Yeah. Partial, yeah.
Tiralo un po' più su. Can you see here, maybe we start to visualize some image?
Yeah.
Entra dentro, Lina, lì. Yes.
Yeah, there it is.
There is the lesion.
Yeah.
Can you see here?
Yeah. Nicely to show, yeah. To see, yeah.
Yeah. Can you see here the lesion? We are a little bit eccentric, not inside, but the lesion is on the
7 o'clock position, yeah.
Is a good position.
Yeah.
And now we can visualize and on the pad if the tool is really in lesion. And to do this is necessary to rotate a little bit the fluoroscope. And on the pad, we could have a reconstruction image that show the bronchoscope and the lesion.
Yeah.
Tienilo più dritto quel broncoscopio, quella punta, più dritta. Now we will see on the pad the 3D reconstruction. Lina. Okay. L'iPad, Michele? Okay, can you see here the 3D image? Zoom. Dai. Okay, and you can see that the bronchoscope is just in contact with the nodule, and you can move the iPad in all the different projection, and you can see in 3D the real position of the nodule and of the bronchoscope. So the lesion seems very well centered. At this point, we will use a flex needle that is a flexible needle with a plastic sheet, very flexible, that can be introduced into the 1.7 millimeter of the bronchoscope. Prepara direttamente il vetrino. And you can see, Phillips, the tip of the needle.
Yep.
Yeah, now we will go out of the sheet with the needle, with the tip of the needle. Okay, the needle should be into the lesion. And now we apply suction with a pistol positioned at the proximal end of the needle. Zoom qua.
So, Stefano, that's a question. Do you have to do the procedures always with intubation or with laryngeal mask, or you can do that also in local anesthesia?
Yes, we will use generally, we can do the procedure also in local anesthesia, but generally we use deep sedation. Even if the patient has not the laryngeal mask, we can use 3-4 cc, 20-30 milligram of propofol and midazolam.
Okay. And also you can also, you use the ultra-thin bronchoscope. Can you also use it with a normal scope?
Of course, you can do it, but with the ultra-thin bronchoscope, you have more possibility to approach the lesion and to bend the tip of the ultra-thin bronchoscope if the lesion is not in contact with the airways.
And there are a couple of questions regarding the technology. Can you connect it to every C-arm, or
yeah,
you need
perfect.
Different?
You can connect with every kind of C-arm.
Okay.
Now they are preparing the slides for the rows that we will see immediately on the microscope. And while the colleague is doing the rows, what we can do is to take more material that we use it as a cell block. in formalin, because we are used to send to the pathologist smear cytology on glass and cell block in formalin. We do both kind of sample routinely.
Okay. And you also will use forceps later?
We can also use forceps, but generally the material obtained by the needle can be enough if the rows support and the rows says there is enough number of cells. The material obtained by the needle can be used for next generation sequences, for immunocytohistochemistry, and the material included in formalin for cell block can be used for PDL1 definition. So we can have histotype definition, immunocytochemistry, and all of sequence. Look at, zoom veloce sul, this is cell block, and you can see a tissue core that we can obtain it with this needle is a lot of material, and if Rose says you are into the lesion, the material is okay. You can see here how many material is possible to send to the pathologist for any kind of definition. And now maybe the rose is ready. For rose, we use a German system that is Hemacolor Marche, that is a rapid stain system using two kind, orange and blue, two kind of color, and the slide is immediately fixed on alcohol for this method. You can see the rose. Can you see the microscopic image, Felix?
Yeah, we're seeing that, yeah.
It seems to me that there are atypical cells. So I look at these are atypical cells, these are not bronchial cells. What we are doing is to evaluate the rows by ourselves. We don't need, for any case, routinely the cytopathologist on site, because I think that every pulmonologist should have a basic knowledge of cytopathologist, because we don't have the radiologist on site, because we know the CT scan and we are able to evaluate the CT scan. In the same way, I think that the basic knowledge in the educational pathway of a pulmonology should include also basic cytopathology element, because it's not difficult to identify atypical cells. Also core. It's not difficult to define atypical these cells and to say, yes, this is a positive rose. And we can do by ourselves. In selected case, when we have some problem, we call the cytopathologist that cooperate with us. But for the routine, we are used to evaluate the slide by ourselves.
So Stefano, Stefano, are there specific requirements for the CAT scan you need to get your augmentation?
No, it's a normal CT scan.
It's different from synchronization or other over system. Every kind of TC scan is absolutely
no specific requirement, Felix. It's different from other navigation systems that require very, very specific criteria to perform CT scan.
It's much easier for the system to have just only the TC scan of thorax and no abdomen and brain together, because there are a lot of imaging is a longer process, but any kind of TC is right. So I think
that now we have 3-4 slides for cytological evaluation, and that can be used also for next generation sequences. And we have, can you see here how much material we have on the for cell block?
So probably in this case, there is a solid nodule, so this one, but the TC scan shows a lot of multiple and bilateral ground glass opacity, very small. So probably, I don't know, also for the comorbility of the patient, if surgery could be considered. So it's very important to have more tissue for next generation sequence, because probably this patient will be candidate to a medical treatment.
So
okay, Felix.
There is one more question to you, Stefano, Lina. How many needle passes you normally do in such a lesion?
How many needle passes?
Needle passes.
We do the first one for rows, and we try to get for the first passes 3-4 slides. If rows show us that the material is enough, the further passes, 2 or 3 generally, are included informally. If the first passes and the rows says us that there is a few material or no material, we try again with slide. So it depends. If the first pass is positive on rows, we generally do other 3 passes to be included in formally in 4-cell block. If the first passes is negative on rows, we try again, try to modify the position on to find a better position of the needle.
Okay, good. So very nice system, very well presented. So just one more question: how easy it is to learn to handle the body vision system? It is
it's very easy. It's very easy because the upload of the CT scan is automatic, is not difficult. You have just to learn to move the C-arm fluoroscope according to the instructions that are generated by the system. Have you seen at the beginning of the procedure, we had to assess the bed of the patient, some centimeter right, some centimeter up, some centimeter down, just to synchronize the position. But otherwise, there is no different technique in comparison to a normal fluoroscopic guided transbronchial approach to peripheral lesion. It's not very difficult to manage. It's something more that you have according in comparison to the traditional fluoroscopic approach. But the technique is not different from the traditional fluoroscopic approach to peripheral lesion.
So Lina and Stefano, in your hand, everything looks so easy. So thanks a lot to Ancona. Great show. Enjoy your weekend, relax, and hope to see you soon again for the next symposium. So thanks to Ancona, and we will move back now to the Netherlands, but not longer to Amsterdam.
Thank you. Ciao, Felix.
Ciao. Bye-bye.